Good afternoon, everybody, and welcome. Thanks for joining us for today's webinar. My name is Lee Montville, and I'm the Director of Special Sales and Business Development at Springer Publishing. For those of you who don't know Springer Publishing, we are an award-winning publisher of nursing and healthcare content featuring books, apps, journals, and digital products. Today's webinar, Changing How We Think About Mental Health Care, Rehabilitation Counseling Approaches to Integrative Care, is being presented by Michael T. Hartley, Vilya Tarvidis, and special guests Irmo Marini and Michael Girard. Michael T. Hartley, PhD, CRC, is an associate professor in the counseling program, Department of Disability and Psychoeducational Studies at the University of Arizona. Vilya Tarvidis, PhD, LMHC retired, CRC retired, is Professor Emerita, former chair of the Rehabilitation and Counseling Education Department at the University of Iowa. Irmo Marini, PhD, CRC, is a professor, School of Rehabilitation, the University of Texas, Rio Grande Valley. And Michael Girard, PhD, LCMHC, LMHC, CRC, is an assistant professor, special education and rehabilitation counseling, Utah State University. Before we get started, I wanted to mention that today's webinar is being recorded. If you miss any portion of the presentation, you can find the video on Springer Publishing's website 5 to 7 days post-event. If you have any questions, please type them into the Q&A box on your Zoom control panel, and I'll bring them up at the end of the presentation. And if you forget to ask a question, there'll be a brief survey sent at the end of the webinar, and you can include your question there. Now, without further ado, we will turn the time over to Michael and Vilya.
So welcome, everybody. So the increasing shift to holistic integrative care is aligned with the core philosophy and practice of rehab counseling. Mental health and physical disabilities often occur in the same person, and rehab counselors are well equipped to serve clients who experience multiple disabilities and understand how they may interact with one another and the environments around them. In this presentation, we are going to discuss how rehabilitation counseling approaches can shift how we understand and approach mental health counseling. So learning objectives for today, participants will learn about rehab counseling, approaches to integrative mental health care. Participants will identify the roles that rehab counseling practices and counselors can play in integrative care. Participants will consider the experiences of persons with co-occurring mental health and physical disabilities. Participants will explore evidence-based rehabilitation approaches to systems of mental health care. And last but not least, participants will have time to share their experiences and ask questions. So we welcome you. We appreciate your time, and we're glad that you're with us. So I'm going to start us off and just kind of talk broadly about integrative care and rehabilitation counseling. So what is rehab counseling? Rehab counseling is a systematic process that assists persons with physical, mental, developmental, cognitive, and emotional disabilities to achieve their personal, career, and independent living goals in the most integrated setting possible through the application of the counseling process. So the counseling process involves communication, goal setting, beneficial growth or change through self-advocacy, psychological, vocational, social, and behavioral interventions. And so this is a definition from the Commission on Rehabilitation Counselor Certification. So with a focus on disability and empowerment, the professional competencies associated with rehab counseling have become increasingly diversified over the years. And so rehab counselors continue to practice in traditional settings such as voc rehab and workers' compensation. Additionally, rehab counselors practice in psychiatric rehabilitation, mental health, and substance abuse. And at the heart of rehab counseling is a multidimensional understanding of disability as a natural part of life. And so this holistic focus is critical because individuals who experience the onset or worsening of a disability may also experience a mental health condition, such as depression or anxiety, as part of the adaptation and adjustment process. And so rehab counseling very much views disability as a natural and normal part of life and kind of avoids the over-medicalization of disability. So with its holistic understanding of people, the practice of rehab counseling fits well with integrative health focused on the whole person, including connections between the body, mind, spirit, and community. Rehab counseling focuses on environments impacting healthcare and quality of life. There currently is a growing awareness of social determinants of health as non-medical factors that influence health outcomes. For instance, food insecurity is experienced disproportionately by individuals with disabilities. Other examples include a lack of safe housing and access to transportation, as well as the traumatic effects of racism, sexism, ableism, discrimination, and violence experienced by some groups of people. So one of the big problems is that across the world, people with disabilities are the poorest of the poor. In the United States, individuals with disabilities are 2 to 5 times more likely to live in poverty than individuals without disabilities. And individuals with disabilities make up almost half of the working age adults in poverty in this country. With high rates of trauma, there is a significant need for trauma-informed care focused on recovery and resilience for those individuals and families impacted by trauma. So trauma is a result of events or circumstances that are physically or emotionally harmful, with lasting adverse effects on an individual's functioning and mental, physical, social, emotional, and spiritual well-being. And trauma, the research on trauma is that it is very common with almost 3/4 of the U.S. general population experiencing a traumatic event and 1/4 developing post-traumatic stress disorder as a result. So rehab counseling fits with integrative care because of its concern with social and environmental factors impacting the health and quality of life among individuals with disabilities. So while rehab counselors possess a wide range of knowledge and skills, it is their focus on individuals with disabilities as competent, capable, and valuable that historically has differentiated them from other counseling professionals and related professionals. Individuals with disabilities are one of the fastest growing minority groups, with 61 million Americans having a disability. This is almost 1 in 4 individuals, adults in the United States. Disability is inherently diverse and including but not limited to physical, a spinal cord injury or epilepsy, sensory, blindness or deafness, developmental, intellectual or autism, cognitive, like a traumatic brain injury or learning disability, emotional or psychological, schizophrenia or substance abuse, and chronic illness, such as HIV, AIDS, or cancer. So in particular, mental illness is a leading cause of disability in the United States. Statistics are about 18% of adults, which is approximately 10 million individuals meeting the criteria for a serious mental illness. So rehab counselors understand mental health as more than a medical condition And so similar to legislation such as the Americans with Disabilities Act, um, rehab counseling views disability as an impairment that substantially limits one or more major life activities, or someone who is perceived as having an impairment by others. And so a mental health or psychiatric disability is identified with an individual with a serious mental illness is unable to perform major life activities. Um, so rehab counseling has long recognized the complexities of multiple or co-occurring disabilities. And I'm now going to turn it over to my colleague, Dr. Marini here, who is someone who has lived with a spinal cord injury for over 40 years and has written extensively on psychological and social aspects of disability. I will turn it over to you, Dr. Marini.
Thank you, Michael, and good morning, everyone. That was a nice introduction. I was flattered to be asked by Michael and Vilya to participate in a chapter in their book. I did so with the assistance of two of my PhD students, Dr. Rajo Pignon, as well as ABD student in our program, Laura Villarreal. They asked me to talk about the lived experience of someone with a disability. And of course, not only my experience, but those of the individuals that I've counseled over the years. I have an active practice in forensic consulting, and so I work pretty much weekly with people with all types of disabilities in litigated cases where they're injured, when they suffer a traumatic brain injury, spinal cord injury, sudden loss of sight, and cerebral palsy, and so forth. We could go to the next slide, I guess, Gina. So, with regards to a sudden onset of a disability like the spinal cord injury I suffered back in 1981, during a varsity hockey game, I was checked into the end boards and fractured my neck, rendering me a tetraplegic, otherwise known as a quadriplegic. I have a C5 injury. I can't move my fingers. I'm paralyzed from the chest down, and I've been in a wheelchair for about 42 years now. There's no question that a sudden onset of any type of disability, especially catastrophic disability that literally tears your life upside down, as well as those of your family members, will have a psychological, emotional impact on you, as it did with me. 1 minute you're walking and you're playing competitive sports and you're totally independent of everything in your life, and the next minute you're having to rely on nurses to give you a cup of water because you can't even reach it on a tray. And so there's no question that I went through many, many months of depression and anxiety. I was 23 years old. I was worried about what I was going to do for a living. I was worried about whether anybody would be attracted to me and whether or not I might be married. I was worried about having children. You just go down the checklist of everything that we would like to accomplish in life. And for me, for that period of time, I wasn't going to be able to do anything for anyone. And I probably lived life on disability. I did go through that depression. I did have anxiety as I began to adapt and go to rehabilitation. I'm originally from Canada. I'll try not to say A too many times, but where we have universal health care. So I was injured on February 10th and actually got out of the rehab in December 5th, spending almost a year in rehabilitation. So comorbidity, when we talk about comorbidity, where you have a physical disability along with a mental health problem, is the co-occurrence of both mental and physical disorders in the same person. Dual diagnosis is the co-occurrence of substance abuse with a mental disorder such as depression and anxiety. So it's basically you're diagnosed with two different disabilities, and in some cases even three. You go ahead, Gina. So then let's talk about quality of life. And I can tell you, and I think it's probably easy to see what I initially went through. Quality of life sucked for at least a good year. I was on disability benefits and lived in low-income housing from 1981 through 1989, basically. But in 1985, I was hired finally after obtaining my master's in clinical psychology. So the World Health Organization defines it as an individual's perception of their own position in life in the context of culture and value systems in which they live, and in relation to their goals, expectations, standards, and concerns. And so let's unravel that for a minute and think about that definition. When you have something like a sudden onset traumatic disability, like some of the ones I mentioned earlier, all of that is tossed into chaos. And there's no question your quality of life and your thoughts about your culture, your value systems in which we live, and the goals that I had before my accident, my expectations, they were all out the window. And again, during that adaptation, during the adjustment process, there was just so many things racing through my mind, and not wanting to live my life sitting in front of the TV, watching soap operas and The Price is Right, and just kind of watching everybody else live their life as I did absolutely nothing. You want to get Rennie, you'll get a chance to ask questions at the end. Be happy to answer. And so that was all thrown into turmoil. Absolutely, quality of life satisfaction, like we see on any TV movie. There's no question, for a while there in the initial months when I thought I wasn't going to be able to do anything, I wanted to die. There's no question. My girlfriend, who actually my wife, and sitting about 40 feet away from me in the kitchen right now, she was stubborn. She didn't listen to me then, still doesn't listen to me now. But I was on a ventilator for a month. I've got a tracheotomy scar under here. And she would come in every morning. She quit her job, came to Toronto, and came up every day for 10 hours. And I would tell her every morning, pull the plug. Well, I would whisper it to her because, of course, she can't talk on a ventilator. But I would whisper it to her and say, pull the plug. I want to die. And again, she just ignored that. So I'm very happy she is. She's the reason why I'm here today. And we can go to the next one, Gina. Thank you. So the lived experience of persons with various types of disabilities and how successfully they may adapt to disability depends on several factors. And these are key to the chapter in that the three of us put together. And I talk about my experience living with a disability, as well as other people I've counseled over the years who maybe also be struggling with a dual diagnosis or co-occurring mental illness. What I found both in the literature and Michael and Velia would attest to this is, for a period of time after your accident, you are not yourself. You're just simply not yourself. But what comes back after eventually adapting to your disability is that your own pre-injury individual personality traits, your temperament, your sense of humor, and your sense of what have you, returns. And I do use a lot of humor in my classes, in my life. And so that slowly began to come back. The second factor is access to community resources. There's no question, Canada with universal health care, much like we have here in the U.S., um, full access to vocational rehabilitation counselors. They paid my way through my education. They bought me an adapted vehicle, spent about $30,000 on adaptations so I could drive, and I continue to drive. With my first vehicle, spent about $35,000 adapting in second vehicle. And what's really important is that, you know, doctors are available, therapists are available, and so forth, as far as community resources and their approachability. I've worked with a lot of people that are injured through workers' comp, and their words, not mine, but, you know, when they call their insurance company or their case manager or workers' compensation, they're often not treated very well because there's this sense that they feel that the person on the other end of the line is saying, okay, so what do you want now? You know, and that's a glimpse of some experiences that people have come to talk about. You know, I can't tell you, adequate health insurance and assistive technology is just key to all of us. I didn't have to worry about this in Canada. Thankfully, I've been a professor in the States for almost 70 years now, and we have good in health insurance, but without the assistive technology for persons who are blind, kitchen utensils, for those who are deaf, closed caption, and for those with physical disability like mine, the ability to drive independently, to the word spontaneity comes to mind. You know, most able-bodied persons can just jump in their car and go catch a last-minute movie. Without transportation for those of us with physical disabilities, we're like a fish out of water. And so with that, I can drive independently to work and teach like I am tonight. And that is key to us being able to do anything. I'm giving a class actually on assistive technology tonight. And, you know, the Michelangelo hand, the bionic hand, and the prostheses nowadays, and the mind-body connection along with computerized and assistive technology allows people who can't type on a keyboard just to look at the keyboard and type letters. Other environmental or external forces that either stifle or block someone with a disability in their life. And so what I've found over the years, and the two psychosocial textbooks I have with Springer, among the 6 others, have been very, very good to me. The societal attitudes are ultra important. If you're surrounded by a society that degrades you, that treats you like second-class citizen, and just basically has negative attitudes towards you, it will have an impact on your emotions and your mental health. Thankfully, I put myself in environments where people know me, and even if they don't, I generally, 9 times out of 10, am treated with respect. And so living down here in the Rio Grande Valley is nice, and anywhere else, everyone's treated me nice. But we all know there are pockets of America where we don't get the same treatment. What I found in the studies that I've done with people with disabilities is that after that initial adjustment or adaptation to disability, that people with disabilities often report having a good quality of life, having a good life satisfaction, and that's regardless of being employed or not. But if they have a roof over their head and they're warm and they have food, and they have good family and friends and support structure, even if they're not working, they can find an avocation or simply just spend more time with the people they love rather than have to do what most of us do and compete in the rat race in the world of work. And so with all those things in place, persons with physical and other types of disabilities that Michael introduced us to earlier, things can be very good. The glass can be half full rather than half empty. Thank you. I'll turn it over now to Delia.
Hello, everyone. I'm delighted to be here, and I'm especially delighted to follow Dr. Marini's remarks. I would like to just reflect for a moment on the importance of having him come before me, both as an individual and an excellent speaker, as well as Michael, but more importantly, as we organized this book, when we began offering it, because of the rehabilitation counseling approaches that we're going to be talking about, it was essential that we put before much of the professionally technical information, the clear focus on the lived experience of disability, because persons with disability are both members of our profession, but also those individuals we seek to assist. And without them and an understanding of that lived experience, the entire enterprise is really doomed to not necessarily failure, but not being as adequate as it should be. So having said that, it's my task to kind of try to pull together some of the key concepts that make rehabilitation counseling approaches particularly important and effective as we specifically entertain our topic today, integrative care. So why are these approaches so effective? In order to give you a sense of that, I'm going to take you on a little bit of a journey to discover the origin story of integrative care and of the rehabilitation services that we now are offering with rehabilitation counseling techniques. You're probably wondering why we're going to go back to the origins. Well, the interesting thing is that the origins of rehabilitation and rehabilitation counseling were incredibly productive and rich. We're going to talk about 3 distinct individuals in the history of rehabilitation, but it's not going to be a moldy-oldie discussion of history because as we march forward, hopefully you will understand that the concepts, the research, and the clinical experience of these individuals really are incredibly important to today's practices, and they have been overlaid with some new terms that we use and a lot more research that has been conducted since these years that have basically pointed us back the importance of rediscovering the unifying nature of these kinds of theoretical frameworks and conceptual frameworks that really contribute so much to the effectiveness of rehabilitation. The first person I'm going to discuss is Dr. Howard Rusk. He may not be a familiar person for a number of people because he was a physician. Right after the Second World War, he was in the Air Force as a veteran of the Air Force, went back into the Air Force to help with rehabilitation efforts in Jefferson Barracks, Missouri. And he began his career there in the convalescent hospital at Jefferson Barracks. And he became very dissatisfied with what he saw as the services, the rehabilitation services. They didn't even coin that term at that point, that the veterans were receiving. So he, through trial and error, developed what is now the origin of rehabilitation medicine, which he's considered to be the founder. And even early on in the late 1940s and early 1950s, he came to a very clear emphasis on equal parts of integrated rehabilitation programming, was using those terms. And the three parts were physical reconditioning, psychological readjustment, and vocational training. He was emphasizing over the physical at that time because of defects he saw in how people were recovering, that their emotional and their social needs were not being attended to, and they were not really experiencing very much progress. There was a problem with emotional concerns, depression, anxiety, and social acceptance. And so he started these programs, and he developed specialized convalescent centers. And of course, he had PT and OT. But guess what? How innovative is this in the late 1940s, early 50s? He was also, and these were the titles they used, hiring athletic trainers, social service workers, personal counselors, and vocational guidance experts. Well, an interesting thing is in the earliest iterations, groups that were not represented was one of my credentialing areas, psychology. He found that these approaches were very effective. He continued throughout his career to forward this. For our purposes today, two things are important that he developed. Through these early efforts, even though we've had periods of time where we haven't emphasized it as much, and he rescored and reiterated the importance of emotional and social factors in making a successful rehabilitation effort, and one which will engage the individual as they go through it and make them a co-participant, not a passive recipient, which he found important to the success of the efforts. The next idea that he had, which is really important to us in rehabilitation counseling especially, is that he saw no false dichotomy between medicine and rehabilitation. He viewed all of the stages of medical treatment as parts of the rehabilitation process. So he came up with a continuum of care and phases of care. And one of his famous quotes that I remember in one of the few lectures that I was gifted to be able to observe was, rehabilitation begins at the very moment that acute illness and surgery are terminated. So he really talked about the importance of seamless transitions and handoffs between both the professional team members in these teams, as well as between the stages of care, and not leaving rehabilitation to this golden moment that you arrive at, but beginning to turn the team and the individual's attention to what are the kinds of things that the person will need when they leave medical care. Can we begin working on some of those things? Mental strengthening natural supports. So he began to talk about even prevention as the first stage, acute intervention, acute rehabilitation, and then community-based rehabilitation as important to the efforts that we're describing. So may I have the next slide, please? Now we're really getting to, I think, what some of the secret sauce of the success of rehabilitation is, and that would be the work of Beatrice Wright. Dr. Wright is renowned as probably the foremost individual developing psychosocial rehabilitation techniques. But as you heard through the remarks of Dr. Hartley and Dr. Marini, these kinds of concepts that I'll be reviewing with you and maybe putting some new dimension to are really at the soul, as well as the practical techniques that have been developed as successful ones in our field. They are really what is the origin story of integrative care as you go around this wheel, and I'll just walk you through it very quickly. But before that, I would also like to just introduce this one quote, and I'll come back to it in a minute. To believe in rehabilitation is to believe in humanity. That's Dr. Bill Anthony. Beatrice Wright said also that significance of a handicap is affected by the person's feelings about himself and his situation. So right off the bat, this is really critically important. putting the respect and care of the individual as a human being, no matter how severe their disability, no matter what the challenge, no matter the lack of resources, putting the concern for that human being as a whole person at the center, which is where, in fact, on this diagram, you see whole person orientation reflected as of key importance. Sometimes we can't always accomplish everything that that person may want at that moment, but if they're recognized and supported in discovering their whole personhood again after disability, we've gone a long way. Now, that's a philosophical idea. It's a value-laden concept that underpins us. But you know what? Further research and further evidence has developed a key phrase, and those people who, for instance, research the importance and the outcomes and effectiveness of psychotherapy have been talking about common factors and therapeutic alliance as being one of the most important and most salient factors in the success of therapeutic efforts. So that all begins with acknowledging the whole person and having that respect, and then looking at the dignity and human rights of the individual as so critical to this, because when the individual is actively conveyed that sense that they are at the center of this, that they are respected, that they are joined with you as a professional in this pursuit, there is actual evidence that is sustainable over a number of different meta-analyses that, in fact, you get much better results. So dignity and human rights, the idea that individuals are worthy of dignity and respect no matter how severe their disability is. Then we follow down in the diagram to individual treatment plans. Another key concept, individuation, is really critical. Disability is very much an individual experience, all the way from the characteristics of the disability or the condition itself. People with spinal cord injury, as Irmo had described, have a variety of different aspects to their physical injury. But beyond that, they have individual differences in their family, their levels of intelligence, their sense of humor, the rigidity of what they're thinking, their financial resources. So if you don't individuate and recognize that individual and just have kind of a rubber stamp plan for all people with spinal cord injury or all people with bipolar disorder, you are not going to be successful and you're not responding to humanity. Another big thing that is part of this whole value-laden origin from Beatrice Wright is that focus on the assets of the individual. There is so much in our society that emphasizes the negative perception of what you can do. And we all grow up in that, even after, as we're children, even when we get disabled, you carry that around in your head. So this is really not as easy as it sounds to emphasize the assets and strengths of the individual. No matter what the circumstances of the person are, we have to believe that we can use those strengths and work toward those strengths and remediate or work on the problems they have. So this idea of personal assets and strengths is now part of the emerging area of positive psychology. It's part of social work practice and strengths-based practice, and it originated here with all of us here in rehab. And it's both got direct physiological aspects where you work toward those strengths, as well as psychological and social aspects. Then interdisciplinary treatment just naturally springs from this. If you're talking about a holistic perspective, you also have to have disciplines that have strengths in those areas, but you don't silo up. You do cross-disciplinary or interdisciplinary treatment, because the whole nature of this value-laden system is we don't silo up, we don't draw bright lines. We're talking about the interaction between parts of our lives and how they work. So cross-disciplinary goal setting, cross-disciplinary treatment, the individual viewing themselves as a whole person that has both psychological as well as physical and social needs, the person, how they view it, the person with a disability, as well as the treatment team, have to be in sync with that broader understanding. And that is kind of obviously integrative care. Because of insurance, because of traditions, because people haven't been trained in these classic rehabilitation approaches, very often you see too much siloing up. Now, societal participation is another key aspect of rehabilitation. You can have a medical success, and I've seen this in all my work in traumatic brain injury. You work very hard, you get to a certain point, and the person returns home to a society or family that doesn't have a built or an attitudinal environment that allows them to continue their growth. In fact, very often they may experience additional problems, handicaps, not beyond their disability, because they're not able to participate in the roles and in the opportunities that they would like to take advantage of. So here's where we have advocacy and a variety of professional skills directed at trying to normalize that experience. And finally, we come back to the client as a co-manager of their own care. The active involvement of the person with disability cannot be overemphasized. These individuals who are people with whom we're working have strengths. They know themselves better, their lived experience of how their disability, how their life works with the plans we're talking about is really critically important. And again, I want to just emphasize there's research showing the actual outcome benefits of engaging people, more compliance, more motivation, more sense of selecting a better goal than the one we might have imagined because of our limitations as professionals. And finally, the person-environment interaction is critically important. That has both societal policy implications as well as more local implications in terms of natural supports and reaching out to communities and making sure buildings are accessible and all of those social and physical environment factors that really can assist the individual and have profound impact on how well the person is able to cope and live with their disability and what kinds of interventions we need to provide. And sometimes just staying in the building and working with the individual is going to be sadly ineffective if we don't branch out, as rehabilitation counselors tend to do, in terms of either themselves or working with someone else on the team that can assist with some of those things like getting assistive technology or getting a modification to a bathroom in a workplace or a school that might be necessary for the individual. So there's a lot of clinical wisdom here, but there's also a lot of new research that has refreshed our appreciation for the brilliant work that Beatrice Wright did. Next slide, please. So the third leg of our stool here in terms of understanding the important innovations within rehabilitation counseling that are really critical to integrative care and successful care would be the focus that began on psychiatric rehabilitation. Now, before I launch into much more content, I just want to clear up one misunderstanding that some of my colleagues seem to have about what psychiatric rehabilitation, the term, means. It doesn't mean that there has to be a psychiatrist or a psychiatric nurse involved. In other words, a medicalized component at the core of it. It's the same thing as saying you have a cognitive disability or a sensory disability, or in this case, a mental health condition. It describes the condition that the rehabilitation is focused at, not the necessity of having a medical leader of that intervention. That's important because I think sometimes our own rehabilitation counseling populations don't understand the power of directing all of the traditional rehabilitation counseling techniques without necessarily having a psychiatrist running that particular intervention. So anyway, our third person that I wanted to just spend a moment with is the person who basically was one of the major drivers and originators of psychiatric rehabilitation, and that's Dr. Bill Anthony from Boston University. Dr. Bill Anthony also was someone who was in the military, and he went into practice and a rehabilitation hospital, Walter Reed, that is, right after the war. And he was doing pretty traditional practice in psychology until he discovered that, in his view, the patients that he was seeing, the veterans that he was seeing, who had psychiatric conditions like PTSD, were not getting the same care as the veterans who had physical wounds. And he was outraged at that. I had numerous conversations with him over the years, and I just was taken aback by how motivating that moment in his life was. And then he began to think about, as a rehabilitation counselor, he had been working with and studying and teaching in rehabilitation counseling eventually, that the very techniques that we're known for, that are described in our book, are actually extremely effective with almost the widest range of populations. And why was it that we were not applying them to people with mental health conditions? The advocacy, the joining with the individual, the recognition of personhood, the demedicalization of care, and looking at what kinds of roles people want to have in the community. So basically, he developed this understanding of, yes, applying rehabilitation counseling techniques directly, didn't matter what your setting was, the techniques and the approach that the professionals provide and the joining with people with a disability were critical in that particular pursuit with psychiatric conditions. So basically, psychiatric rehab helps individuals by considering research and that they do themselves, choosing and achieving major roles that they want to enter into, being a student, a worker, a spouse, and also looking at a specific environment that they want to be successful in, that would be personally meaningful to them. Now, it's just pragmatic and logical that if the individual selects a role and an environment, you're going to see a lot of learning that's certainly transferable, and gains that are transferable, and assistance in managing depression and anxiety as the person becomes engaged and begins convinced that they can be ready and they can be successful to take on challenges step by step with the support and assistance of an integrated, cooperating group of individuals that are going to assist them with this process, but that places them at the center of this process. I know that it can be daunting if you're not used to working with people with severe and chronic mental disorders, and especially if you see them in an acute phase, for some of us as rehabilitation counselors. But that should not really make you feel as if you don't have a place to play. When those individuals are stabilized through other services and return to our communities or are making progress, all of us in rehabilitation counseling can provide some assistance. And so my first point is that rehab is a robust model. It has applicability to all these diverse groups of individuals that we've discussed. The second point is the continuum model of mental health needs and interventions is there for clients and professionals to understand where they're at in an ongoing process and what can be provided to them through integrative care to make them progress further. There's an acronym, PLICIT, and that's an old term that's been around for a while, especially when you're talking about some of us who trained in sexual readjustment counseling in the Plicit model, basically, the P stands for permission, so that you can begin to talk with people about their mental health condition. Are you feeling some anxiety? You seem really as if you're having difficulty with feelings of sadness, or you're just not feeling very motivated. So that even if you don't have advanced therapeutic skills, if you're working in some setting where that's not a focus, you can open the door. You can give the person permission. You have permission to ask. You need to know some of these things that will impact the individual and help to provide readiness for them to see someone. You're giving the feeling to the person that you will accept talking about that. Even if you're a vocational counselor or if you're working on some other aspect of the person's life, you can, in fact, open a door, even if you yourself don't feel prepared, because of maybe that image you may have, someone who's been frankly psychotic in your presence. That's a little frightening. Maybe you don't have skills and readiness for that. You can develop them, but right now, with this other client, something's not going right. So why don't we open the door, find out what's going on? Then we can both work to get some resources to that person, even if you can't do it yourself. The LI of Plicit, PLISSIT, is limited information. Sometimes clients are told something about some psychiatric condition or some medical aspect, and they may need some help through you providing some interpretation or helping them prepare for asking questions the next time they're seen. You might also be aware, because rehab counselors get training in medical aspects, that certain of the medications they may be on may have some psychological spin-offs, some side effects. For instance, certain types of blood pressure medications can create depression, and that needs to be acknowledged and monitored. Maybe they're not with their physician long enough for that to be uncovered, but you have uncovered it, and you can prompt that individual to say, it's not something I can address, but I do know that it might be worth talking to your physician about whether or not you're having some depression based on some of the medications you're taking for your blood pressure. So there are levels of involvement in providing some limited information. And you might also just provide the basic limited information that Dr. Marini gave us. If you have a serious traumatic event in your life, it is normal, it is human to be anxious. It is important to understand that. You have been traumatized. These are the effects of trauma. It would be natural for you to be depressed or anxious, and normalize that so the person may feel that. And I had a client once tell me, you know what, you've just told me that my brain is scrambled after my brain injury, and now you're telling me I'm going crazy because I'm depressed? And we had a long conversation that kind of unlocked and normalized the ability to understand that both there's a psychological reaction to this traumatic accident you've been in, but also there are some effects through your brain metabolites that would create the possibility that you would have a organic element to your depression for a time as well, post-recovery. So there are a lot of things that you can do with limited information. Specific suggestions is the SS and the PLISSIT, and that is where you might give specific suggestions if you're qualified to do that. If the person's depressed, we all know, if they're with a psychiatrist or someone, that you could also supplement that by talking about increasing general wellness behaviors, making sure the person takes their medications on a regular basis. Wellness approaches to making sure you get good sleep, good nutrition, doing some exercise, which has got some proven effects on decreasing depression, for instance. And then intensive therapy. And that may not be something you're ready to do. You may wish to train, but as a generally well-trained counselor, you may not be ready for intensive therapy, but you may become intrigued and begin to go for additional training and credentialing in various areas. So that's what the Plicit model is. So what is psychiatric rehabilitation and its contributions to integrative care? That would be the last thing I would want to address there. Um, on this slide, and that really is, rather than going into the particular techniques and the excellent evidence-based practice research that's now supporting all of these interventions, I would urge you to take a look at Chapter 20. But I would just simply summarize by saying that psychiatric rehabilitation is working to help people with mental health conditions consider, research, choose, and achieve major roles. We're talking about role goals here. The focus on what the individual wants to achieve in which role, and giving them tools and support from a team that's organized to provide that through a variety of psychosocial and other interventions. Another key goes back to Beatrice Wright, and that is valuing the personhood of the individual. That first quote that we had, I had read, is a good one to just emphasize. To believe in rehabilitation is to believe in humanity. That is a curative factor. It is at the core of general rehabilitation counseling, but it is particularly key here in psychiatric rehabilitation. Once you're imbued with those kinds of ideas and goals, then learning the particular techniques is a task. It's important, and you can review those. We already have many of those in our repertoire, but they will come much easier. And then the last slide for me, please. So very quickly, yes, that was the origin story through the kind of experiences of three different people. Today, our current societal context makes them even more relevant. The first part of our set of gears here is that people with disabilities are people with disabilities. Well, that sounds like there's a typo there. It's not. It's to remind us of that last point I made. It is the person first, the lived experience of the person, the co-management of that process, the engagement of the individual that is part of the key here, and why that really can, if you can get that going, the individuation and the humanity. Now, the next part of the gear, the largest gear, is that right now we have a lot of stressed people and stressed systems in our world. We're living in a post-COVID world. There's a lot written and thought about, but there is no doubt that the social fabric of our treatment systems is really being tested. Part of what's going on in that system, as well as in society, is we have a mental health crisis for everyone. It's harder to get resources. Things are more fragmented. There are if you've been traumatized at all, you just turn on the news and there are so many ways in which your level of anxiety, your level of depression, even if you're struggling with a physical disability, a sensory disability, a cognitive disability, can get ramped up, and the people around you may not also be in the healthiest place to provide the kinds of supports. So we really have to step up our consideration of some of these curative factors that we're talking about in rehabilitation. We have the rise of chronic and debilitating diseases, both through natural progression of medicine, having people live longer, having people survive, but survive with challenges that we need to meet, as well as now we have a whole population that we're not even beginning to understand of post-COVID individuals with a variety of both pulmonary, cognitive, and other challenges that they're trying to navigate, as well as some of them being told that, no, it's all in your mind, which presents an additional challenge. We have more fiscally conservative landscape now to get treatment resources to people. These are effective techniques. They will work. We can't keep being siloed up. We have to practice those warm handoffs. We have to maximize our treatment efficiency. They're also pushing more treatment back into the community with earlier discharges, and so community-based rehabilitation techniques. that kind of integrative care, which is a challenge in the community because you're not always physically present, but we are now used to using a variety of electronic techniques, allow rehab to shine if we were willing to take on that challenge. So we have that. We could keep going with a variety of these things. But again, this current environment we're living in is an important time. And last but not least, the evidence-supported interventions gear is the last gear here. That is an important driver because we've, since the origin of rehabilitation counseling in 1954, and all these people and others that have contributed, the concepts, the clinical expertise, the work that was done to develop techniques based on that old research, there's a lot more research and emphasis on evidence-supported interventions. And you know what? It's coming out really good for the concepts we're talking about. The terms might have shifted a little bit, the combinations may have shifted, but you need to look at a variety of the work areas that are developing strong evidence for these practices. The book really deals in that. We didn't shy away from that part of it at all. We've got a chapter on evidence-based practices. The chapter on psychiatric rehab deals with it somewhat. And then also there's been a substantial amount of work done on vocational interventions that we talk about in chapter 19, but also in chapter 15. There's a chapter there by Dr. Strausser on career development and employment techniques that touch on a number of these matters. So if you need some convincing that there are important techniques that can be utilized to support all of this integrative care, it is really there. So I would conclude my remarks, and I would want to turn it over to Dr. Michael Gerald. He's uniquely positioned to cap off all of how this works together. He's trained both in traditional vocational rehabilitation counseling. Also, he's a behavior analyst. He is a mental health counselor, and he's a skilled clinical educator, and has developed a clinic and has a long-standing practice across a variety of populations, as well as being an excellent scholar. So, Dr. Gerald, I welcome you.
Thank you, Dr. T. So I will keep my remarks short. I recognize that we're running out of time, and I want to make sure that participants here today have enough time to be able to ask questions of the presenters who are here. Oddly enough, as Dr. Tarvidas mentioned, I currently direct a teaching and learning clinic here on Utah State University's campus, and that is actually where I need to be here in a couple of minutes to see a client of mine. The clinic I operate focuses on psychotherapy services for persons with chronic illness and disability. And the chapter I provided for the book or for the text is on counseling and mental health, with a lean towards counseling and mental health in rehabilitation settings and contexts. And three important themes emerge with respect to not just the text, but how I've constructed my practice. So I'll share those themes briefly, and then I'll go into what generally underlies effective clinical counseling support for persons with chronic illness and disabilities. The first theme is meaning making. Psychotherapy is inherently a phenomenological practice in that what is most important, and certainly what opens the door for empathy with the persons we serve, would be the meaning making that people engage in response to the experiences that they have. Now, this obviously transcends life experiences, but it becomes really prominent and important for persons with chronic illness and disability. As Dr. Marini has already alluded to and discussed today in depth, persons with chronic illness and disability have a wide array of responses to chronic illness and disability. And so as a clinician, engaging with clients, meaning making that they have themselves engaged in regarding their experience with chronic illness and disability is most important and foundational to the work that we do. Additionally, central to the work that we do is the therapeutic relationship. I've been fortunate enough to have the liberty of constructing a clinic with a vision and philosophy that matches not only my background as a person with a disability, but also my background in rehabilitation counseling and my experiences in clinical mental health counseling. And what I have found is that for persons with chronic illness and disability, largely as a consequence of the medical model, they have often experienced objectification and pathologizing at the hands of healthcare professionals. So central to the work that we do in our clinic is the lived experience of persons with disabilities and the emotional bond that they forge with the clinician that they are working with. That then dovetails into another theme that emerges in the chapter and also informs the work that I do with clients and also the work that I hope my supervisees do with their clients. And that is the role that structural inequality plays in someone's response to a chronic illness or disability. As Dr. Marini noted, yes, certainly persons with chronic illness and disability can also have co-occurring diagnosable mental health conditions. However, a lot of distress that I see in my clinic isn't due to organic mental health disorders that are diagnosable using the DSM-5-TR. Instead, a lot of it has to do with our perceptions of disability, whether or not disability fits with what I believe God's plan was for me, how disability threatens the life that I thought I was going to have going forward. And a lot of that ties back to structural inequalities for persons with disability, which can not only include lack of access to appropriate healthcare, but also lack of access to social environments. It can also include toxic messaging around chronic illness and disability. All of these things inform the work that I do in my clinic and also informs the construction of the chapter. This then leads into where I'll finish for today, and then I'll kick it back to my other presenters here with us to answer questions. But effective support in a clinical setting for persons with disabilities requires holistic acceptance of persons as they are. One of the things that I caution practitioners I work with on is if we immediately start intervening with respect to a person's experience of chronic illness and disability, they describe anxiety around chronic illness, and I immediately start trying to intervene and fix their anxiety, what I am demonstrating is that their anxiety is unacceptable. This doesn't necessarily seem on its surface like a bad thing, but when people cannot resolve symptoms that arise as a result of their experience of disability, they might feel like they are not doing something right, as if there were a correct or proper way to adjust to chronic illness or disability. Our focus in therapy, psychotherapy for persons with disabilities should always be on meaning making that people engage in with disability. What does it mean that you have a chronic illness? What does it mean that you have a disability? It means I won't live the life that I thought I was going to live. It means I'll be alone forever. It means I'll have never-ending suffering. That's where we place our emphasis in practice. And finally, the goal of mental health support for persons with CID shouldn't be symptom reduction. Interventions should not be central to the work we do. It should be helping promote adjustment or response to disability, however that may look for an individual. I'll share one last thing. One of the definitions that comes from rehabilitation practice that I find to be really helpful in my work is optimal versus maximal functioning. And I think a lot of times we try to promote maximal functioning for clients when in reality, once we have defined what would be optimal for them, we can better support and foster adaptation to chronic illness and disability. Thank you for your time. Thank you for having me. I'll go ahead and stop talking there.
Thank you, Dr. Gerald. I really appreciate your time and everyone's time. So thank you to the presenters. Just real briefly, we kind of covered the origin of integrative care in rehab counseling, talked about the co-occurring mental health and physical disabilities, and statistics are I've read 68% of people with a mental health disability also have a chronic illness or disability. Talked about rehab counseling approaches, and I just want to emphasize things like holistic, client-centered, strength-based, asset-based, with a focus on the environment and empowerment. And so Thanks to all the presenters. And I'm going to now turn it over if we have time for questions.
Sure. Thank you, Dr. Hartley. Thank you, Dr. Tarvidis. Thank you, Dr. Marini. And thank you, Dr. Gerald. Again, this is Lee Montville with Springer Publishing Company. We are going to go ahead. We are recognized that a lot of you have stayed with us till the current time, so we appreciate that. We're going to reply to the couple of questions we had via email, so we will follow up with the individuals who had some questions, since we're cognizant of everybody's time, but we're thrilled you were able to join us. Dr. Hartley, if you could switch to the final slide, that would be great. So the book that everybody has been talking about is The Professional Practice of Rehabilitation Counseling. As you know, the editors are Drs. Hartley and Tarvidis. Feel free to purchase it from our website, springerpub.com, and you can use the code webinar30 to save 25%. Thank you again to our presenters. As I mentioned before, a copy of the recording of this will be sent to everybody who has attended and who has registered about 5 to 7 business days from today. So we thank you all again. Thank you again, presenters, and we wish everybody a happy and healthy rest of the week. Take care, and thank you.